Immune suppression changes the odds and the care pathway, but it does not decide the fate of one tumor by itself.
Hold on, what does that actually mean for a patient's real-world risk? Are we talking about an inevitable outcome here, or is this just a change in how we manage the disease?
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. To answer your question, we really need to define exactly who we're talking about first. You see, immune suppression isn't just one single uniform condition. It actually comes from several different sources. We're looking at patients with solid organ transplants, blood cancers like CLL, stem cell transplants, HIV, or even folks taking medications for autoimmune and inflammatory diseases. These groups definitely do not share one universal risk number or a single copy-paste treatment plan. The underlying cause and the actual depth of that suppression matter immensely.
Okay, but if they don't share a single risk number, how much does the risk actually go up? We need a baseline to put this into perspective. Let's look at solid organ transplantation, which is where cutaneous squamous cell carcinoma, or SCC, becomes much more common. A 2024 meta-analysis actually estimated a pooled standardized incidence ratio of 45.9. But, and this is absolutely crucial, remember that 45.9 is just a population estimate. It is not an individual prediction for your specific fate. Individual study estimates in that meta-analysis actually range from roughly 5-fold to more than a 200-fold increase. Things like organ type, time since transplant, medication regimens, and honestly, even your latitude change that number. So throwing around a single universal multiplier, that's kind of misleading.
So if that multiplier is so wildly variable, what does a patient actually look out for when we get to Section 1, Warning Signs and Evaluation? Because the practical consequence for us is the cumulative burden of these tumors over time, right?
Exactly. A patient might develop dozens of tumors over time, which naturally increases the chance that at least one is going to carry aggressive features. That's exactly why we look for these specific warning signs. We're talking about a lesion that is growing quickly. Maybe it's painful, tender, numb, or tingling. Or perhaps it's bleeding, repeatedly crusting, thick, or horn-like. It might be non-healing, recurring in a previously treated site, or accompanied by a brand new lump in a nearby lymph node basin. These signs literally change the cost of waiting. In an immunosuppressed patient, a changing or painful scaly spot must be treated as a serious medical question, not just brushed off as an ordinary sunspot.
Does the patient's immune status override everything else when a clinician is actually planning out the treatment?
It definitely raises the concern, but no, it doesn't override the tumor's own biology. The clinician still dictates the treatment plan based heavily on the tumor's specific features: the site, size, depth, borders, recurrence history, pathology, nerve involvement, and nodal examination. Immune suppression is a solid reason for earlier, more deliberate assessment, but it's not a reason to assume every single tumor will automatically behave badly.
Which naturally brings us to a very common question. Does every CSC in an immunosuppressed patient require Mohs surgery? The direct answer is no. Mohs, or another complete margin method, is highly valuable when borders, recurrence, anatomy, or pathology make leaving residual tumor behind especially costly. Plus, it preserves tissue for future tumors and repairs. But it is not automatically required for every single CSC in every single immunosuppressed patient.
Let's look at how the care pathway actually shifts between an immunocompetent and a transplant patient. For surveillance, transplant patients usually need much closer skin checks and coordinated prevention. For local treatment, complete margin assessment becomes especially valuable simply because recurrence and multiplicity matter so much more. And crucially, if there's a new node or rapid growth, there is a much lower threshold for urgent staging, like a CT or MRI, and multidisciplinary review.
Okay, so this right here is the core unresolved tension of this entire explainer. If a patient has a transplanted organ and an aggressive skin cancer, how do we actually control that cancer without risking the organ or the patient's overall health? That is literally the most difficult scenario we face, and we will get to advanced systemic treatments in just a moment. But first, let's jump to Section 2, Prevention and Skin Surveillance, to see how we focus on protecting the organ. The most effective way to do this is to stop these advanced tumors from developing in the first place through risk-matched surveillance.
Speaking of prevention, I hear a lot about nicotinamide supplements online. Do those work here? Well, nicotinamide did reduce keratinocyte cancers in a high-risk immunocompetent trial, but the 2023 OnTrans trial found absolutely no benefit in solid organ transplant recipients. You really cannot simply transfer results from immunocompetent adults over to transplant patients as though the populations were interchangeable.
What can help selected patients dealing with a high tumor burden, particularly kidney transplant recipients, is a medication called acitretin, or sometimes converting their regimen to sirolimus. But the trade-offs are significant. Acitretin's benefits wane as soon as it's stopped, and it comes with lipid and liver effects that require strict monitoring. And switching to sirolimus? It has limited tolerability and was actually associated with an increased mortality risk in a large individual participant meta-analysis.
And this brings us to an absolutely vital rule. Never, ever stop or change your anti-rejection or immune-modifying medicine just because of something you read online. Reducing one risk can easily create another, far more dangerous one. Medication changes belong exclusively to a coordinated decision with your transplant or prescribing team. No exceptions.
So let's address your earlier question and move right into Section 3, Advanced Tumors and Medications, to see how we control advanced disease when those preventative measures just aren't enough.
Expert host PD-1 checkpoint inhibitors can produce very meaningful responses in advanced CSCC by actually shrinking the tumor. But they can also trigger the immune system to attack the transplanted organ. A 2025 meta-analysis really highlights this stark trade-off. In the CSCC subgroup, the cancer response rate was an impressive 61%. However, the 6-month acute organ rejection rate was 23.3%. Cancer control and graft protection absolutely must be considered together by a multidisciplinary team.
There is some evolving hope, however. A small Phase 1 study recently treated 12 kidney transplant recipients with advanced CSCC using semiplimab, alongside a very specific MTR and steroid-based immunosuppression protocol. The response rate was 46%, with zero rejection or graft loss observed in those 12 participants. But it is critical to note here, this is promising, yes, but it is far too small and organ-specific to guarantee safety for everyone.
Okay, with all these competing risks, the cancer, the organ, the medications, what should a patient actually do at their very next appointment to navigate Section 4? Coordinating your complete care? They should follow this specific coordinated care checklist. First, bring the full pathology report, not just the diagnosis name. Things like depth, margins, and nerve involvement dictate the entire pathway. Second, tell the dermatologist exactly why you are immunosuppressed and list every single medication. Third, ask if a nodal examination, imaging, or oncology review is needed. And fourth, ask what follow-up interval fits your specific tumor burden. There is no single every 3 months indefinitely rule that fits everyone.
Remember, this is all about making sure your treatment plan matches the individual tumor and your overall health. We invite you to read the complete evidence-based article and review these findings over at skintrust.com. And please, always discuss individual decisions directly with your treating clinician. Dr. Hocker created SkinTrust to provide free evidence-based dermatology education and help patients and clinicians make clear decisions together. Ultimately, treating high-risk SCC isn't just about fighting the cancer. It's about asking, how do we protect the whole patient? To explore that further, join us for our next explainer where we tackle high-risk basal cell carcinomas and navigating reconstructive choices.